Carbohydrates. All right, so an intro. So carbohydrates are essential macronutrients. Their main function is to provide energy to the body. They are found in foods like grains and fruits and vegetables and dairy. The role of the carbohydrate as an energy source is as an immediate energy source. So carbohydrates are broken down into glucose. Glucose then enters the bloodstream and is used by the cells for ATP production. They are also an efficient fuel. They are our preferred source for energy due to a quick metabolism, particularly important during physical activity. Glucose is the primary fuel for the critical organs, so the brain. The brain relies almost exclusively on glucose. In prolonged fasting, it may adapt to ketones, but glucose remains vital. Red blood cells, they lack a mitochondria, and they rely entirely on anaerobic glycolysis of glucose for energy. Retinal cells, they are highly active metabolically. They use glucose as their primary source of energy as well, and they use it for visual processing. Carbohydrates for a major food and energy supply. So these are found in a wide variety of foods. So your complex carbs like whole grains and legumes or beans, simple sugars, fruits, and sweets. They provide about 4 calories per gram, and it forms the largest portion of many dietary guidelines, worldwide. That's usually the number one that they want you to get. Glycogen storage. So for your body's energy reserve, there's liver glycogen, and that maintains blood glucose levels between meals during fasting, and it can be quickly mobilized if needed. The muscle glycogen is used locally during physical activity, and it cannot contribute directly to the blood glucose because it lacks glucose 6-phosphatase. Again, glycogen is the storage form of glucose. So it is important to have a steady glucose supply. Glucose homeostasis is vital for your survival. Tissues like your brain, retina, and red blood cells that we talked about earlier are highly glucose dependent. Glucose must be consistently available in the blood to be able to supply these tissues. There's also a pretty narrow range that needs to be maintained in your body. The normal fasting glucose is between 70 and 100 milligrams per deciliter. It's also tightly regulated by hormones. So insulin will actually lower your blood glucose, where glucagon, cortisol, and epinephrine will actually raise the blood glucose. So if you have low blood glucose, it's also called hypoglycemia. If it drops too low, your nervous tissue can lose its energy supply. The brain cannot store glucose. It needs a continuous supply. So this can result in confusion, seizures, loss of consciousness, coma, or death even if it's prolonged. Some mechanisms to prevent hypoglycemia is to make sure, well, your body basically ensures that there's supply through glycogenolysis. It's a breakdown of your liver glycogen. Gluconeogenesis is the formation of glucose from non-carbohydrate sources, and also hormone control, and that is mainly by glucagon and cortisol. For your glucose, it is the fate of your glucose anyway. It is ingested by carbohydrates. So main dietary sources are going to be starch from plants, glycogen from animal sources through though it's pretty minimal in our normal human diet. Both are polysaccharides and require enzymatic breakdown. The digestion of carbohydrates. So we have salivary amylase, and that begins carbohydrate digestion in your mouth. It breaks down the polysaccharides into shorter chains called dextrins. Then we have pancreatic amylase, and that continues digestion in the small intestine. It converts dextrins to disaccharides, also known as maltose, lactose, and sucrose. And then once it gets to the gut, the disaccharides are broken down into monosaccharides, and that is by the brush border enzymes. So you have maltase, lactase, sucrase, and that breaks them down into glucose, galactose, and fructose. Monosaccharides are absorbed by the intestinal epithelial cells. So you have glucose and galactose, and then fructose as well. They are transported to the liver via the portal circulation. Once in the liver, the glucose can be immediately used for energy. It can be stored as glycogen for glycogenesis as well. And it could be converted to fat if the intake exceeds energy that is needed. There's also a video on this slide, so take a look. Utilization of glucose. So glucose activation has phosphorylation. So the steps of that is basically before glucose can be metabolized inside the cell, it has to be converted to glucose 6-phosphate or G6P. The enzyme hexokinase or glucokinase is found in the liver. This step traps glucose inside the cell, so it cannot exit once it is phosphorylated. So the metabolic fate basically of the glucose 6-phosphate, so once that is formed, it can enter into 3 major pathways. The first one is the Embden-Meyerhof pathway, also known as glycolysis. This is the main anaerobic and aerobic pathway for ATP generation. It converts glucose to pyruvate to ATP, which is energy. If oxygen is present, pyruvate enters the mitochondria for aerobic respiration. If there is no oxygen, the pyruvate changes to lactic acid, and that's anaerobic glycolysis. We have hexose monophosphate shunt pentose phosphate pathway. This generates NADPH, and this is for the biosynthesis and antioxidant defense. Ribose 5-phosphate, and that's for the nucleotide synthesis. We also have glycogenesis, and this is the storage pathway. It converts glucose to glycogen, and that is mainly in the liver and the muscle. This is important for the blood glucose regulation in the liver. It also is for energy reserve during exercise found in your muscle. The anaerobic glycolysis in muscle, so during intense exercise, oxygen may be insufficient. Muscles will then rely on anaerobic glycolysis, where glucose is converted to pyruvate and then to lactic acid. It still produces ATP, but it's less efficient than the regular aerobic metabolism. This is critical short-term energy source for skeletal muscle. Glycogenesis is the process of converting glucose to glycogen, which is the storage form. It occurs mainly in the liver and skeletal muscles, and it is regulated by insulin, which stimulates the glycogen synthesis after meals or after you eat. So the release of glucose, so glycogenolysis is the process of breaking down glycogen to glucose 6-phosphate or G6P. This happens in the liver. The G6P can be dephosphorylated to free glucose and released into the blood. In the muscle, the G6P enters glycolysis locally because muscle lacks G6P. It's regulated by glucagon and epinephrine. This stimulates the glycogen breakdown during fasting or times of stress. Another source of glucose during hypoglycemia, so when blood glucose is low, the body maintains or tries to maintain levels by glycogenolysis, which is the first initial response, and gluconeogenesis, which is more of like a long-term response that your body will use, and it does this by using glycerol, which is from fat breakdown, lactic acid, which is from the anaerobic glycolysis, and amino acids, especially alanine, from your muscle protein. For regulation on your carbohydrate metabolism, so the organs involved for the glucose regulation is the liver. That is central to maintaining the glucose balance. It helps store glucose as glycogen. It releases glucose via the glycogenolysis or gluconeogenesis. The pancreas is the endocrine kind of control center. It produces your key hormones that are needed, such as insulin and glucagon. And other endocrine glands that are also needed for metabolism of your carbohydrates is your adrenal glands, so cortisol and epinephrine, pituitary for your growth hormone. This also affects glucose metabolism indirectly. Blood glucose during fasting, so if you do like a short-term fast like overnight, glucose comes mainly from the liver for glycogenolysis. Do not like that word today, I'm sorry. Prolonged fast, so if you fast for more than 24 hours, glucose is generated through the gluconeogenesis, and that is from the amino acids to glycerol and lactate. Hormones that play a role in all of this is, once again, insulin. This is from the beta cells of the pancreas. This is secreted when blood glucose is high, and this promotes glucose uptake by cells. It also promotes glycogenesis, or storage of the glucose, and inhibition of gluconeogenesis. Then we have glucagons from the alpha cells of your pancreas. It is secreted when blood glucose is low, and this helps to stimulate do not like this word, I'm sorry, glycogenolysis, or converts glycogen to glucose, and then gluconeogenesis, which is the new glucose synthesis. Insulin. So what is insulin? This is a peptide hormone. It is produced by your beta cells in the islets of your Langerhans in the pancreas. The function of the insulin, the primary role of this is to help facilitate the entry of glucose into cells. So once glucose is inside the cells, it is used for energy, or ATP production. It is stored as glycogen, once again in the liver and the muscle, and is converted into fat in your adipose tissue. It increases glucose metabolism by activating glycolysis and glycogenesis, and it also inhibits gluconeogenesis and glycogenolysis. So regulating the insulin release, as mentioned, this insulin is released when the blood glucose is high, like after a meal. It is not released during hypoglycemia, as that would, continue to lower your glucose levels. All right, glucagon. This is the primary hyperglycemic hormone. It is produced by your alpha cells in the islets of the Langerhans in the pancreas. It is released during times of fasting, stress, and hypoglycemia. The function of glucagon, like I mentioned, is a hyperglycemic agent. So what that means is it increases your blood glucose, and it does this through two main pathways in the liver. The first pathway is your glycogenolysis, and that breaks down glycogen into glucose, and gluconeogenesis, which forms new glucose from non-carb precursors. The target tissues of this is primarily the liver, and the goal is to maintain glucose levels during fasting and starvation. So just remember that glucagon increases plasma glucose. It is antagonistic to insulin, and it helps protect the brain and other glucose-dependent tissues during energy shortages. Epinephrine and cortisol. These are stress hormones that increase your blood glucose. So epinephrine is produced by the adrenal medulla. This plays the role in the fight or flight response. The actions that this does is it inhibits insulin release, and it increases plasma glucose levels by increasing glycogenolysis, which is the breakdown of glycogen, and increasing lipolysis, which is the breakdown of fats. The purpose is it provides immediate energy for emergency responses. And then we have cortisol, which is produced by the adrenal cortex. Its actions for increasing plasma glucose. It does this by increasing gluconeogenesis, which is new glucose synthesis, and increasing liver glycogen storage. It also increases lipolysis as well. The role, it helps maintain energy supply during prolonged stress and fasting. So just as a reminder, epinephrine is an acute stress hormone that spikes blood sugar rapidly, and it suppresses insulin. Cortisol is a chronic stress hormone, which supports chronic hormone supporting sustained glucose availability by promoting gluconeogenesis and fat breakdown. GH, which is growth hormone, and ACTH. Growth hormone is produced by the anterior pituitary gland. The effect of glucose is it increases plasma glucose levels, and it does this by it decreases glucose entry into cells, so it causes the glucose to remain in the blood. It also increases glycolysis, which breaks down the glucose for energy. Overall, this conserves blood glucose for vital organs by reducing peripheral uptake. And then ACTH, which is adrenocorticotropic hormone. It is produced by the anterior pituitary gland. The role in glucose regulation is it stimulates adrenal cortex to secrete cortisol. And then cortisol increases blood glucose by converting liver glycogen to glucose, which is glycogenolysis, and promoting gluconeogenesis, which is the new glucose synthesis. The trigger, decreased cortisol levels can stimulate ACTH release to help maintain glucose balance. So GH, or growth hormone, helps keep glucose available by limiting its cellular uptake, where ACTH controls cortisol release, which supports glucose production during stress or fasting times. Thyroxine and somatostatin. So understanding the hormonal change of blood glucose is critical for grasping how the body maintains energy balance. So those two important hormones that are involved in this regulation are thyroxine and somatostatin. Thyroxine is produced in the thyroid gland. Its role in glucose metabolism is to increase blood glucose levels. The mechanisms include enhancing glycogenolysis, which is the breakdown of glycogen to glucose, and by promoting gluconeogenesis, which is the creation of glucose from non-carbohydrate sources, and also increasing intestinal absorption of glucose. So the overall effect of thyroxine is it helps to ensure sufficient glucose availability by mobilizing glucose stores and increasing absorption. Somatostatin is secreted by D cells of the isolates of the Langerhans in the pancreas. Its role in glucose metabolism is it increases blood glucose levels indirectly, and it does this by inhibiting the secretion of insulin, which actually lowers blood glucose. Also glucagon, which raises blood glucose, growth hormone, which affects the glucose metabolism. So the overall effect is it modulates and balances the actions of other hormones which regulate blood glucose. So it does this, as I mentioned, indirectly. Hyperglycemia. So the definition is an increase. That's what hyper means, right? So increase in plasma glucose levels. So when plasma glucose levels rise, insulin is released to help lower the glucose. So the cause of hyperglycemia, there's usually a hormonal imbalance that can disrupt normal glucose regulation. Diabetes mellitus is, a disease caused by this. There's type 1, which is insulin-dependent diabetes, and type 2, which is non-insulin diabetes. And then we also have a third one, which is gestational diabetes. So type 1 diabetes, the definition is it is a hyperglycemic state which is caused by the destruction of pancreatic isolate B cells, which leads to insulin deficiency and a tendency for ketoacidosis. The cause of it is a cellular mediated autoimmune destruction of those pancreatic B cells. And the prevalence is it accounts for about 10 to 20% of all diabetic cases. It is most common in childhood and adolescence. Some clinical features of this is it will have an abrupt onset. They will have an insulin dependence, and they are prone to ketosis. Symptoms for this disease is polydipsia, which is excessive thirst, polyuria, which is frequent urination, polyphagia, which is increased eating. They'll have rapid weight loss, mental confusion, loss of consciousness possibly, and hyperventilation. Complications is they could have nephropathy, which is kidney damage, neuropathy, which is nerve damage, retinopathy, which is eye damage, and they can also have an increased risk of heart disease. Then we move on to type 2 diabetes. This is a hyperglycemic state which is caused by insulin resistance combined with insulin secretory defect. Insulin resistance results in the relative insulin deficiency, which will constitute, this actually constitutes for the majority of diabetes cases. Most patients with diabetes type 2 are obese or have increased body fat distribution in the abdominal region. This does have a strong genetic predisposition as well. So if you have a family history of it, there's higher odds of you or someone down your line getting it as well. And typically this will have an adult onset with milder symptoms compared to type 1, and ketoacidosis is rare. Other types, so we have impaired glucose tolerance. So glucose tolerance levels above normal but below the diabetes threshold. And then we also have gestational diabetes, and this is diabetes that develops during pregnancy. And then it will usually just return to normal after they have the baby. It's associated with increased perinatal complications, and it also can have an increased risk of developing diabetes later in life as well. Infant risk for if their mother has gestational diabetes is they can have an increased risk of respiratory distress syndrome. They also have a potential for severe hypoglycemia immediately after the umbilical cord is cut. All right, so lab findings for type 1. Clinical presentations, the patient will show dehydration, so they'll have an electrolyte imbalance and acidosis. Pathophysiology of this is ketones are produced from fatty acid oxidation, decreased bicarbonate and carbon dioxide, and that's due to the Kussmaul respiration, which is your deep, rapid breathing to blow off carbon dioxide. Laboratory findings, you'll have an anion gap, which I don't think we talked about yet, but we'll get to it. And that may exceed 16 millimoles per liter, increased serum osmolality, low sodium levels, and an elevated potassium level. Clinical features for untreated type 2, their plasma glucose levels could be greater than 300 to 500 milligrams per deciliter. They can also be having some severe dehydration. Non-ketotic hyperosmolar coma. You can have a plasma glucose of greater than 1,000 milligrams per deciliter, normal or increased sodium and potassium levels. They can have a slight decrease in their bicarbonate and an increased blood urea nitrogen, or BUN, and creatinine, and also an increased serum osmolality. So the differentiation from diabetic ketoacidosis is higher glucose levels and osmolality, elevated BUN in absence of ketones. Some risk factors for diabetes mellitus is, as we mentioned, obesity, family history, minorities, history of gestational diabetes, or delivering a baby that's greater than 9 pounds. Having a low HDL, increased triglycerides, or having a history of impaired glucose tolerance. Also, it's recommended that all adults over 45 years of age have a fasting blood glucose done every 3 years, just to be proactive and try to catch it. Some diagnostic criteria for diabetes is a random plasma glucose. So a random blood glucose level greater than 200 milligrams per deciliter, in the presence of certain symptoms like polyuria, polydipsia, fatigue, unexplained weight loss, can show that they have, a diagnosis for diabetes. And this was, again, a non-fasting one since it's a random glucose. Then we move on to the fasting plasma glucose. Fasting is defined as no caloric intake for at least 8 hours. So generally water is fine, but they don't really want anything else. So for a diagnosis for diabetes on a fasting blood glucose would be anything greater than 126 milligrams per deciliter. This test is simple and it is commonly used for screening. And then we move on to our oral glucose tolerance test. So this is after fasting. The patient consumes a glucose load, or it's a glucose type drink, kind of tastes like an orange soda, of 75 grams of glucose. And then we will do a blood glucose 2 hours later. If that 2-hour plasma glucose level is greater than 200 milligrams per deciliter, that can confirm the diagnosis of diabetes. So this test evaluates the body's ability to handle glucose, and it's more sensitive in detecting impaired glucose tolerance. So the confirmation of diagnosis, so any one of the above abnormal test results can be confirmed by a repeat test on a different day, just to help establish that diagnosis. This helps to ensure accuracy and avoids false positives. If they have other symptoms, then maybe that secondary one isn't needed. It just kind of depends. And then we kind of go back to that early diagnosis. So the importance of it, early identification of diabetes can allow for an intervention. It can reduce the risk of long-term complications as well, such as cardiovascular disease, neuropathy, nephropathy, and retinopathy. So regular screening is recommended, especially for high-risk populations. Gestational diabetes screen. So Gestational diabetes mellitus is a form of glucose intolerance that is generally recognized during pregnancy. Early identification and management is going to be crucial to prevent complications for both the mom and the fetus. Risk factors for screening. So only women with the following risk factors should be screened for gestational diabetes. Age is greater than 25 years old, overweight or obese, if there's a family history of diabetes, or if they belong to a minority population with a higher risk of diabetes. Although some places will have every pregnant woman do it, just kind of depends on where you're at. Screening procedure. So step one, we'll do a 1 hour post-load glucose test. So we will give them a 50-gram oral glucose drink. We're going to measure that plasma glucose 1 hour after the load. And if that glucose level is greater than 140 milligrams per deciliter, then we're going to move on to step two. If it's 100 or if it's less than 140, they're done. There's no, risk at that point. But if it's above 140, we're going to go on to step two, and that's when they would do a 3-hour glucose tolerance test. So they will administer, or we will give an 100-gram oral glucose drink. Then we're going to measure that plasma glucose as a fasting level at 1 hour, 2 hour, and 3 hours after they have taken that drink. So diagnostic criteria for gestational diabetes can be made if there's 2 or more of the following plasma glucose thresholds if they have been met or exceeded during the 3-hour. So if their fasting is greater than 105 milligrams per deciliter, if the 1 hour is greater than 190, if the 2 hour is greater than 165, and if the 3 hour is greater than 145. So again, they only need to have 2 of those be higher than those thresholds to be diagnosed with gestational diabetes. All right, hypoglycemia. Hypo is low, right? So that means a low glucose. So hypoglycemia is characterized by the decreased plasma glucose levels. It will represent an abnormally low level of blood glucose, which can affect normal body function. Physiological response when there is a low glucose level. So when the plasma glucose levels fall between 65 and 75 milligrams per deciliter, the body will start to release glucagon and other hyperglycemic agents. These hormones act to increase blood glucose by stimulating glycogen breakdown and gluconeogenesis. So your body's trying at this point, right? Symptoms of hypoglycemia. These symptoms usually appear when plasma glucose falls to around 50 to 55 milligram per deciliter. And these symptoms may include sweating, shakiness, weakness, confusion, and irritability. Fasting hypoglycemia. This is kind of a serious form of hypoglycemia. Patients with fasting hypoglycemia are unable to maintain a stable plasma glucose level during periods of fasting, and this can lead to severe symptoms and requires urgent evaluation and management. Some causes, symptoms, and some lab findings for hypoglycemia. So cause of hypoglycemia, it is the B isolate cell insulinomas, or tumors of pancreatic beta cells, which can produce an excess of insulin. Other insulin-producing tumors in the body, if there's ethanol-induced hypoglycemia due to impaired gluconeogenesis. There can also be drug-induced hypoglycemia, like insulin could be an option. Severe liver disease, which would result in impaired glucose production and storage. And then enzymatic defects, which can affect glucose metabolism. So symptoms of hypoglycemia is they will have an increased hunger, sweating, nausea and vomiting, dizziness, nervousness, shaking, blurred speech and vision, and they'll also have some mental confusion. Laboratory findings. So on our end, what we'll see if someone has hypoglycemia is a decreased plasma glucose level. Hypoglycemia, we would run that by on our chemistry analyzer, and we would know that it was low. So in summary, basically, hypoglycemia can arise from a variety of causes, most notably insulinomas, or those tumors, and drug effects. Symptoms can range from hunger all the way up to neurological issues, and then diagnosis would be confirmed by us in the laboratory as they have evidence of low plasma glucose. Genetic defects, so glycogen storage disease type 1 or von Guericke disease. So this is the most common congenital glycogen storage disease is glucose 6-phosphatase deficiency. It's also known as von Guericke disease. We like to have multiple names for things for some reason, so bear with me. Pathophysiology, so the deficiency of glucose 6-phosphatase enzyme impairs the final step of glycogenolysis and gluconeogenesis. It results in severe hypoglycemia due to the inability to release free glucose into the bloodstream. It causes accumulation of glycogen in the liver. Some clinical features for these patients with severe hypoglycemia, they'll have metabolic acidosis, ketone bodies in the blood. They'll have increased lactate and alanine levels as well. They could also have hepatomegaly due to glycogen buildup. They could also potentially have hyperlipidemia, which is an increased blood fat, hyperuricemia, which is an increased uric acid, and growth stunting or retardation. Management of this is they would have a control hypoglycemia by avoiding fasting and preventing hypoglycemic states. They would do this by regular feeding or continuous glucose supplementation if needed. Galactosemia, which is another congenital disorder of galactose metabolism. The congenital deficiency of enzymes involved in galactose metabolism. It's a common cause of failure to thrive in infants. The most common enzyme deficiency, galactose 1-phosphate uridyl transferase deficiency, is the most common enzyme defect. This leads to accumulation of toxic galactose metabolites. Clinical features of these patients is they would typically have diarrhea and vomiting in the affected infants. If untreated, it can cause mental retardation and cataracts. In the laboratory, we're going to see hypoglycemia, hyperbilirubinemia, which is elevated bilirubin, which can cause jaundice or yellowing of the skin. We also would have accumulation of galactose and galactose 1-phosphate in blood and tissues. So the management of this is to remove galactose and lactose from the diet immediately after diagnosis, and that would help to prevent any further complications. Glucose measurement, so specimen collection and handling. So types of specimens for glucose testing is serum, plasma, and whole blood. We can also use spinal fluid and urine as well. Some considerations is, when we're using whole blood, glucose concentration is approximately 15% lower than serum or plasma glucose. Specimens should be refrigerated immediately. Separate the plasma or serum from blood cells within 1 hour of collection, and that helps to prevent glycolysis, within the tube. Anticoagulant use, we can use sodium fluoride as an anticoagulant in blood collection tubes. Sodium fluoride actually inhibits glycolysis by preventing glucose degradation in the sample. Patient preparation, patients should be fasting for 10 hours. Some places say 8, some places say 12. Just go by your facility's guidelines, but we're going to say 10 for this purpose. So patients should be fasting for 10 hours before sample collection to ensure that we get an accurate fasting glucose measurement. So just as a reminder, proper specimen handling is critical for accurate glucose measurement, as with all testing in the lab. We want to make sure we use appropriate specimen types to prevent glycolysis with that sodium fluoride anticoagulant. We want to make sure we're refrigerating these samples because that also helps with that. And we also want to separate the cells promptly as well. Glucose measurement methods, we have glucose oxidase method, and that is specific for the beta-D glucose. It's commonly used, but it is subject to interference. So the interfering substances that can decrease the glucose value is uric acid, bilirubin, and vitamin C. Interfering substances that can increase values is bleach or hypochlorite. We also have the hexokinase method. This one's considered the more accurate method. It has less interference compared to the glucose oxidase. It is accepted as the reference method for glucose measurement as well. Some interference issues for glucose. So if you have a specimen that is grossly hemolyzed, it may cause falsely decreased glucose levels. If you have a specimen that is increased bilirubin levels, that may also cause a falsely decreased glucose result as well. Oral glucose tolerance test and the postprandial glucose test. So the procedure for this one, the patient consumes 75 grams of that glucose drink. Plasma glucose is measured 2 hours after that drink. So to diagnose for this, if plasma glucose is greater than 200 milligrams per deciliter at 2 hours and confirmed on another day with elevated random or fasting glucose, then this patient can be diagnosed with diabetes mellitus as well. You can also do an oral glucose tolerance test, although this is not really recommended anymore under the new ADA guidelines. Glucose tolerance test preparation, no exercise prior to test, no eating or drinking except water, and no smoking. So the test procedure for us, at least, we would draw a fasting glucose, we would give them that drink, and then we would measure the plasma glucose 2 hours after giving. Glycosylated hemoglobin, or hemoglobin A1C. I said we like having multiple names, right? So there we go. It measures long-term glucose levels. It reflects the average blood glucose over the past 2 to 3 months. So the mechanism, or how this works, is glucose binds to hemoglobin, which forms glycosylated hemoglobin. The main form is hemoglobin A1C. It's created when the glucose attaches to the beta chain of hemoglobin A. The rate of hemoglobin A1C formation is directly proportional to plasma glucose concentration. So if you think about it, red blood cells live about 120 days. So hemoglobin A1C will reflect the glucose exposure over that time span. For your A1C, your normal range is between 4.5 and 8. We would use an EDTA whole blood specimen, so that lavender top tube. And the preferred method for testing is an affinity chromatography.